So today we will be having a discussion on the topic epithelial dysplasia. So when we talk about epithelial dysplasia, the question comes is that what exactly is epithelial dysplasia? Now, if we just talk about this epithelial dysplasia basically we can define it as it is a spectrum of architectural and cytological changes in the epithelium which are recognized as transformation into a getting transformed into a pre-malignant pathosis. And this definition was given by WHO. It means that anything or any changes which are visible in the epithelium as well as within the structure of the epithelium and within the cell itself. And those changes, if they are depicting the transformation of a normal tissue into a pathological tissue, then that could be called as a dysplastic changes within the epithelial specimen. Now, what could be the etiology and risk factors which can lead to epithelial dysplasia? The foremost and the most common etiological factor is tobacco. This tobacco could be consumed in the either smoke form or smokeless form. Both these forms of tobacco are harmful and that could be a cause of a dysplasia. Second thing is alcohol consumption. Alcohol consumption directly is not responsible for the causation of epithelial dysplasia or dysplastic changes, but it can be a factor which can act as a synergistic factor. It means it can strengthen the effect of tobacco, resulting in the more fast progression of epithelial dysplasia. Third thing is human papilloma virus infection. Any sort of viral infection could be a cause of change in the architectural and cytological structure of a tissue, and that can lead to a dysplasia. Second thing is chronic irritation. If a person is if in the oral cavity the person is experiencing if the person has a habit of wearing if the person is a denture wearer, and if the denture is not properly fitting in the oral cavity, then that chronic irritation which is created due to the wearing of that irritational denture can lead to the development of dysplastic changes or a lesion in that area, that is called as dysplasia. Or any sort of sharp teeth which is constantly causing a irritation at some specific part of the oral cavity can be a cause of the development of a dysplastic lesion or epithelial dysplasia in that area. It could be due to genetic predisposition. Sometimes patient is having everything normal in the oral cavity, but due to the genetic predisposition, there could be development of dysplastic changes in the oral cavity. Third thing is nutritional deficiency. Any sort of nutritional deficiencies could be the cause of development of your epithelial dysplasia or dysplastic changes in the oral cavity. Now, what is exactly the pathogenesis? Whenever the dysplastic changes happen in the oral cavity or the oral epithelium, they basically affect the genetic architecture. So it could be due to the mutation, genetic mutation or inherent genetic mutation. Second thing, when the cell starts behaving abnormally, the cell starts behaving abnormally only when the cell cycle is dysregulated. So any sort of disruption of the normal cell cycle can be cause of dysplastic changes in the oral cavity. Third thing is when the cell proliferation is not normal, and when the cell cycle is over, when the normal time of the cell is over and the cell is about to die, but that cell is not able to die. That means reduce apoptosis. It means the cell is not able, the programmed cell death is affected. It is not taking place properly. Then the cells will keep on proliferating, and the cell whose cell cycle has been over, they will not be shunted out of the cell cycle. That will result in aggregation of the abnormal cells. That could result in the development of epithelial dysplasia. Third, last thing is when all these factors, when due to the constant irritation in some specific area, there is accumulation of abnormal cells. Now, from where does these abnormal cells come? Basically, when the irritation is constant, then that constant irritation brings about multiple architectural and psychological changes. And due to the architectural and psychological changes, there occurs accumulation of various abnormal cells, which can result in the development of epithelial dysplasia. Now, when we talk about epithelial dysplasia could be diagnosed with the help of multiple markers, because as such we cannot detect where exactly which part of the epithelium is affected by the dysplastic changes. And so basically markers help us to detect where exactly which part of the epithelium is affected. So epithelial dysplasia basically is associated with expression of various markers. And these markers act at molecular level also, as well as they act on the cellular level also. So these could be molecular markers which are acting at the DNA or protein level, and they could be cellular markers which act on the cell itself. So now, why do we use these markers? These markers basically help you to assess the risk of progression. They help you to assess the risk of progression of the dysplasia of any pathology to oral squamous cell carcinoma. More the area involved in the epithelium, more the dysplastic changes in the epithelium, more severe will be the pathology and more faster will be the progression of that pathology to the oral squamous cell carcinoma in the oral cavity or any part of the body. Now, what are the markers which we can use? So key markers which are involved in dysplasia, the first and the most common marker is your TP53, that is tumor protein 53, which is also called as policeman of human genome. And this is basically a tumor suppressor gene. In the human body, this protein basically acts to suppress any kind of tumorous activity. And if this gene is mutated, then there will be no suppression on the tumor activity, and that will result in the development of a dysplastic changes throughout the body. Second thing is MIR21. MIR21 basically regulates various biological processes, and when these biological processes like normal cells division, normal cell proliferation, when these biological processes are affected, then that might lead to the development. And why these biological processes are affected? Because MIR21 is either genetically mutated or it is not working properly, then that could result in the development of pathologies in that person. Third molecular marker is P116, P16, INK4A, and cyclin D1. Now, these are basically tumor suppressor genes, and their main function is to regulate the cell cycle. Because these markers are associated with regulation of cell cycle, so basically they prevent uncontrolled cell division. And if these two proteins or protein markers are mutated or they are not working properly, then that could result in the uncontrolled division, which could result in the development of a pathosis or epithelial dysplasia, dysplastic changes in that in that specific area. Next is Chi67. Chi67 that is very commonly used marker for assessing the how rapidly the cells are proliferating. Basically, Chi67 regulates cell proliferation, and if Chi67 marker is mutated, then that will result in the development of that will result in the excessive proliferation of the cells at that specific area, resulting in the dysplastic changes. Next is MMPs. MMPs have a role in tissue remodeling, various physiological processes, as well as wound healing and angiogenesis. And if MMPs are not functioning properly or if they are mutated, then that will hamper with the normal tissue remodeling. That will also hamper with the wound healing, and because if ulcer is there in the oral cavity and if ulcer is not healing, then that could be due to the defective function of the MMPs and excess, because when the when the any sort of excessive cell proliferation, when any sort of excessive cell proliferation occurs in some specific area, then in that area angiogenesis is also, that is neovascularization is also seen, because when the cells will be proliferating to supply nutrients to those excessively proliferating cells, more blood vessels will be required. So neoangiogenesis is seen because of the defective function of MMPs. Now next marker is CFOS and CJUN. Now these CFOS and CJUN are basically proto-oncogenes. These proto-oncogenes basically are present in your body, but they remain subtle. They remain subtle and in a senile stage. And they become activated only when a specific stimulus is given to them. And if these two genes are dysregulated, then they may lead to the development of tumor. They may help in the progression of tumor, and that they also have the potential to help in the migration of a tumor from that specific area to different parts of the body, that is metastasis. Next is HSP70, that is heat shock protein 70. Now heat shock protein 70 has a role in maintaining the protein homeostasis in the body. protein homeostasis in the body, that the level of proteins within the body is maintained by a heat shock protein 17. And HSP 17 is also needed by the cells for their survival. And if this HSP 17 protein is defective or dysregulated, then that can hamper with the protein homeostasis, which can result in the accumulation of protein within the cells and also can lead to the excessive proliferation and the pathological death of the cells in that specific area, resulting in dysplastic changes. Now, this was all about the markers associated. Now we come to the next heading, next part of this discussion, that is classification systems. Now, various classification systems have been given regarding this epithelial dysplasia, out of which the first classification system which was given was a binary or two-tier system that was given by Kuzan et al. In 2006. Now, Kuzan et al. Classified the epithelial dysplasia into two categories. That could be low grade, that could be high grade. Now, low grade means mild dysplasia. High grade means moderate, severe, or carcinoma in situ. Now, they classified into two tiers. Now, this grade, basically this the classification focused only on two grades, and the high grade was having all the three variants, that is moderate, severe, and CS, carcinoma in situ. Now, here in this high grade, all the three variants were combined so as to reduce the inter-observer variation. Otherwise, this Kuzan et al. Classification was based, they just classified into two categories, low grade and high grade. Low grade means mild dysplasia, high grade means moderate, severe, and carcinoma in situ. And why this high grade was having all these three types? That means this was having all these three types so as to reduce the inter-observer variations. The next is WHO classification, which was given in 2005 and 2007, and this was a three-tier system. Now, this classification was based on architectural and cytological changes. On this basis, WHO classified it as mild dysplasia, moderate dysplasia, and severe dysplasia. Now, WHO in 2022 gave a four-tier system, and this is the most accepted system. Now, in this system, they named the fourth category also, which was carcinoma in situ. So mild dysplasia, moderate dysplasia, and severe dysplasia were same as that from the 2005 classification, but carcinoma in situ was added. So mild dysplasia, now what this was based purely on architectural and cytological changes. Now, so what does the mild dysplasia meant by what was the meaning of mild dysplasia by WHO? WHO said that if the lower one-third of the epithelium is showing the abnormal changes, then that will be called as a mild dysplasia. It means that if the dysplastic changes are visible in the lower one-third of the epithelium, then we can say that this is a mild dysplasia. Moderate dysplasia means if the dysplastic changes are visible in the two-thirds of the epithelium, then that will be called as a moderate dysplasia. If dysplastic changes are present in more than two-thirds of the epithelium, but not the entire, then that will be called as severe dysplasia. And if the entire epithelium is involved, then that will be called as carcinoma in situ. And this carcinoma in situ now progresses into your frank carcinoma or well-differentiated squamous cell carcinoma. Next classification was Lubjana's classification. Lubjana's classification, which was given by V. Cambic and I. Lennart in 1995. Now, this Lubjana's classification basically was not meant for oral dysplasias, but it was mainly used for laryngeal dysplasia, laryngeal dysplastic lesions. But it can be used for oral dysplasias also. So basically, they classify dysplasia as simple hyperplasia, abnormal hyperplasia, atypical hyperplasia, and carcinoma in situ. Now, what is abnormal? When we say simple, it means the cells are abnormally increasing in number. What is abnormal? There are two terms, abnormal and atypical. Abnormal hyperplasia means the cells which are increasing in number looks like the normal cells, but they are increasing in number. That will be called as abnormal hyperplasia. Next is atypical. Atypical means the cells which are increasing in number, they are not looking same as that of a normal cells, but they are abnormal cells. So these are the cells which are increasing in number. They are not the normal cells. They are typically abnormal cells. That's why we call it as atypical hyperplasia. Next was carcinoma in situ. It means the border which is a very faint line between a severe dysplasia or atypical dysplasia and a frank carcinoma. Next was squamous intraepithelial neoplasia classification or SIN classification, which was given by Friedman and Osborne in 1976. This classification is not very commonly used nowadays, but it is for the historical purpose, and that is very commonly asked in the exams. SIN classification was given by Friedman, and it classifies the dysplasia into SIN1 means mild dysplasia, that is squamous intraepithelial neoplasia 1 means mild dysplasia, SIN2 means moderate dysplasia, and squamous intraepithelial neoplasia classic 3 means severe dysplasia or carcinoma in situ. Now, what is the histopathological classification of histopathological basis of all the classification? Now, if we talk about histopathological basis of all the classification basically relies on two factors. That is basically three factors: architectural changes and cytological changes, and how much epithelium is involved. So, architectural features broadly involves changes in the rate apex, changes in the stratification, and cytological changes includes nuclear size, cell size, mitosis, pleomorphism. All these features change in the nuclear cytoplasmic ratio. So basically, and the most important factor, how much depth, how much part of the epithelium is involved. So depth of epithelial involvement. So basically, entire classification revolves around all these three factors, that is architectural features, cytological features, and depth of epithelial involvement. So now what are the basic clinical features when we come across a case of epithelial dysplasia? So if we talk about the site, any part of the oral cavity like buccal mucosa, tongue or floor of the mouth could be affected by the dysplastic changes in the oral cavity. Now this epithelial dysplasia or dysplastic pathosis could appear as a white patch, that means leukoplakia. As it is visible there, it could appear as a white patch like this, leukoplakia. It could appear as a red patch, that is erythroplakia, or it could appear as a mixed lesion, that is erythroleukoplakia, that is a mixed patch. Now, usually the dysplastic changes are asymptomatic. It is asymptomatic and they appear normal, but they could have a rough or granular texture. And when they have a rough or granular texture, then the person could present with some sort of symptoms like pain or a burning sensation in that specific area. Like it is very commonly seen in granular type of leukoplakia. So it could be rough. Usually it is asymptomatic, but sometimes it could be rough or granular. And when it is rough or granular, then it could present with some kind of symptoms. Now coming to the histopathology. Histopathology basically relies on evaluation of architectural and the cytological changes. Now, what all changes we see? Architectural changes involve your disordered maturation from basal to squamous cell. If the cells are not able to mature in a proper way, that means from the basal layer to the squamous cell, the maturation is not very proper, then that could result in the development of a pathosis in that specific area. Next is increase cell density. If the cells are excessively proliferating, it means the basal layer is usually single cell layer. But if the number of cells in the basal layer is increasing, that means the cell density is increasing. That is not a normal sign. So the number of cells will be increasing. That is that is another basal cell hyperplasia. If the many a times the stratum spinosum also increases in thickness, that is increasing cellular density. Basal cell hyperplasia that I told previously, that increasing the number of basal cells. Next is dyskeratosis or premature keratinization. If usually when the cells are formed from the basal layer, they move towards the upper part of the epithelium, and at the topmost tier, they release their keratin which has been formed, which is gradually formed by them. If these cells which are supposed to release the keratin at the topmost part, release the keratin in between either in the stratum spinosum or stratum granulosum, then that will be that is dyskeratosis or abnormal or premature keratinization, which is not the normal feature. Next is bulbous or drop-shaped rate apex. Rate ridges are usually finger-like projections. But if these rate ridges become or rate apex becomes broad, then that is not a normal sign. And sometimes these rate apex show bifurcations or divisions or branches, and that is also the abnormal sign and symptom. Next is loss of polarity. the cells which are usually in the center. These cells, or the nucleus which is usually in the center of the cell, the loses its polarity. Either it goes towards the bottom or either it goes towards the top. Then this is called as loss of polarity. Loss of polarity is an indication of any sort of abnormal pathology. So this is called as abnormal stratification, where the cells are abnormally arranged, and this is basically bulbous or drop-shaped retipex. And here we can see the rated edges are showing the bifurcation, which is like this. The rated edges are showing the bifurcation, which is not the normal feature. And here we can see basal cell hyperplasia. The basal cells are abnormally proliferating and replicating, which is not the normal feature. This is called as basal cell hyperplasia. And this is basically your individual cell keratinization. It means these cells which were supposed to form the keratin at the topmost part, liberated the keratin in the middle part of the epithelium. That is individual cell keratinization. Now, coming to the next, cytological changes. Now, in the cytological changes, we can see changes in the nuclear shape, that is anisonucleosis. That could be abnormal variation in the nuclear size, abnormal variation in the nuclear shape. Nuclear shape is basically nuclear pleomorphism. Nuclear size means anisonucleosis. Cell size means anisocytosis. Cell shape means cellular pleomorphism. There could be change in the nuclear cytoplasmic ratio. There could be presence of atypical mitotic figures. Now the question comes is that what are these mitotic figures? Mitotic figures basically happens is that the nucleus is actively dividing. They keep on dividing, and that actively dividing nucleus is indicative of that the cell is very active. The cell is very active, and very active cell could be seen only in case of pathologies. So cell shape, increase in the presence of atypical mitotic figures, and increase number and size of the nucleoli, increase nuclear hyperchromatism. Nuclei will be staining very dark like this. We can see the nuclei are very dark. This is nuclear hyperchromasia. There is increase in the nuclear size, increased mitotic activity. There will be individual cell keratinization, and there will be apoptotic mitosis. It means the cells which are about to die, they start dividing rapidly. That is, apoptotic bodies are there. These apoptotic bodies, they keep on dividing. That is called as apoptotic mitosis. So this is basically a dead cell which is there. They keep on dividing actively. It is basically due to a chromosomal abnormality. This is basically because of the chromosomal abnormality. So this is basically your increased nuclear cytoplasmic ratio. You can see that the nucleus is moved toward, the nucleus is increasing in size, and when the nucleus is increasing in size, only a very small part of cytoplasm is left around the nucleus, which results in increased nuclear cytoplasmic ratio. This is basically your dysplastic cell. You can see the nuclear hyperchromasia. The nucleus is very darkly stained. That is nuclear hyperchromatism. So basically all these things are seen in case of and there we can see a single cell or individual cell keratinization could be seen in different parts of the epithelium. Rather than this keratinization should be visible here itself. But if you are able to see this keratinization in this part, then that means this is an abnormal thing. We can see abnormal shape of the nucleus, which is called as dyskeratosis. We can see this nucleus is abnormal in shape. All the nucleus at different parts of the epithelium are abnormal. That is called as dyskaryosis. At some parts, the nucleus might be enlarged. Nucleus is enlarged. This is called as karyomegaly. And we can see the cellular pleomorphism. The cells have different shapes. So you can see that the cells have different. The cell is very small. Here the cell is big. All the cells in different parts of the epithelium, they have different shape. This is called as these all are your basically dysplastic changes. Now, how do we grade after studying all these different types of dysplasia? We grade the dysplasia. So the grading of the dysplasia could be done in mild, moderate, and severe dysplasia. Mild dysplasia means the changes are confined to the lower third of the epithelium, as I told you in the earlier slides. And moderate dysplasia means the changes are visible in the 2/3 of the epithelium like this. The changes, if this is mild dysplasia, the changes are confined to the lower part of the epithelium. That is your mild dysplasia. If the changes are visible in the 2/3 of the epithelium, we call it as a moderate dysplasia, as it is visible in this diagram. And if the changes are visible in the more than 2/3 of the epithelium, or either the full thickness of the epithelium, that is in the carcinoma in situ, when we can say that it is severe dysplasia or carcinoma in situ, like this. So here the dysplastic changes are visible in the entire length of the epithelium, or it might be more than the 2/3 of the epithelium. If it is more than 2/3, then we can call it as a severe dysplasia. And if it is in the entire length of the epithelium, we can call it as a carcinoma in situ. Now, what is the clinical importance of this? Clinical importance of the dysplasia lies in the fact that by assessing the dysplastic features, we can know about the increased risk of malignant transformation. So, dysplastic features helps us to assess the risk of malignant transformation. Second thing is, it helps us to plan the treatment and assess and also help us to assess the need for follow-up. And it also helps to assess that in deciding the treatment, what sort of treatment you are, what sort of surgical treatment you are going to give, whether it should be a conservative excision, whether it will be a R&D, or it is radical, or whether it will be a marginal dissection. So it helps us to decide the surgical excision margin. So basically dysplasia helps us to ascertain many things, and so that we can, in the future when we are going to treat the patient, we can have a good prognosis. Now, management. How can we manage? We can manage the dysplastic lesions by eliminating the risk factor, that is cesating the tobacco or alcohol, by doing a biopsy of a dysplastic lesion. By doing the biopsy, we can know what sort of dysplastic changes are there. And third, by doing a regular follow-up and monitoring by doing a regular follow-up of the patient and monitoring for checking the incidence of any sort of recurrence or progression. We always advise a regular follow-up of the patient, so as to avoid any incidence of recurrence or progression in the person in whom the surgery has been done for dysplasia. Now, prognosis of the dysplastic lesion. Prognosis basically relies on what sort of dysplasia is there, what is the size of the lesion, what is the site of the involvement. Because if the lesion is there on the tongue, then tongue lesions have a very poor prognosis. If the mild dysplasia is there, then the prognosis is very good. Size of the lesion. If the size of the lesion is very small, then it means the damage is very small. So in that case, the prognosis will be good. So another factor is risk factor persistence. Even after knowing that the person even if the person continues the habit of smoking or like that, even after knowing about that he has contracted some pathology, then if the risk factor is mild, then there will be low risk. If the risk factor persistence is moderate, if the risk factor is moderate, then there will be moderate risk. But if it is severe, then there will be high risk. So early detection helps you to improve the prognosis, because earlier you detect, better will be the prognosis in any disease. That is a very fundamental rule for any of the pathosis. Now, summary. Epithelial dysplasia, basically it is a pre-malignant pathosis with a distinct histopathological features. Epithelial dysplasia has a distinct histopathological features where grading plays a vital role in management and prognosis, because the more lesser is the grading, more mild is the grading, more better will be the prognosis and better will be the management. You can plan out the management accordingly. But if the grading is on the higher side, it means it is severe, and in that case you have to change your management, and the prognosis will also change. Early diagnosis and therapeutic intervention can help in preventing the transformation of dysplastic lesions into the oral squamous cell carcinoma. Now, summarizing all that what we have discussed, the 4-tier system which was given by WHO in 2022, that is the most commonly accepted classification. SIN, that is squamous intraepithelial neoplasia classification, was a 3-tier system. Binary system was 2-tier system that was given by Kunaz et al. In another there is Lubjana's classification that is basically used for laryngeal dysplasia, and that that is basically a 4-level classification. And the most widely accepted classification of epithelial dysplasia is WHO's 4-tier classification, which was given in 2022. Now, key points which are supposed to be remembered regarding dysplasia is the dysplasia is, first of all, the most common site of the for occurrence of any dysplastic lesion is floor of the mouth, and the most poor prognosis of the any lesion or any dysplastic lesion of poor prognosis for any dysplastic lesion in the oral cavity is for the lesion that is occurring on the tongue surface. Gold standard diagnosis is for the diagnosis of dysplastic lesion is biopsy. Now, WHO grading is based on extent of epithelial involvement. WHO graded into mild, moderate, severe. They graded it on the basis of how much of the epithelium was involved. Now, what all markers we can use? What all markers could be used for checking the proliferation of the tissue? That is basically your Chi-67. So this was all about dysplasia. This was the insight which we are supposed to get while we are discussing about epithelial dysplasia. So thank you very much.